Good evening and namaste everyone. On behalf of Intas Pharmaceutical Limited, I Dr. Mithilesh Nayak welcome you all to this unique webinar series, Practice Pulse in Endocrinology. In this fourth edition, we are going to discuss about the important addition in the diabetes armamentarium, that is the SGLT2 inhibitor. And to guide us, we are having eminent endocrinologists from India. And to moderate this session, we are having with us Dr. Subhankar Chaudhary, sir. Dr. Chaudhary is a professor and head in the Department of Endocrinology at SSKM Hospital, Kolkata. He is currently editor-in-chief in Indian Journal of Endocrinology and Metabolism, and is actively associated and past president of Endocrinology Society of India. So without wasting much time, I invite Dr. Subhankar Chaudhary, sir, onto digital podium. Over to you, sir.
Hello, very good evening. Welcome once more to our monthly meeting. I hope the previous ones have been of some use to you in a practical sense. This time we are going on to the diabetes field, and frankly I must say when the SGLT2 inhibitors were being talked about a few years back, maybe 5-6 years back, I wasn't very impressed. Yes, they could reduce glucose levels a little bit, but what's so great about them? What about they're causing symptoms like increasing the urine output. So that's a basic symptom of diabetes. So you're using a drug that may worsen the symptom of diabetes. So those were many questions that ran through my mind, as well as many other endocrinologists that have spoken to. But over the years, at least I have been proved wrong. This has taken a very strong position across the globe, in our country as well, especially because of its effects even beyond glucose control. And to understand all of that, and partly the reason why it's become particularly more popular in our country is because it's a non-injectable preparation and has various other attributes, which our learned speakers will definitely talk about. So what we have done is divided the talks in two parts. One looks more at the understanding of what these SGLT2 inhibitors are, what they do, how they do. Is it just about glucose control, or are there mechanisms whereby it could produce other effects as well? And the other part will be the clinical use of the SGLT2 inhibitors. And in that context, of course, we feel a little bit sad, possibly, that the class of molecules are probably being snatched away from endocrinologists and being taken over by the cardiologists first, and then maybe the nephrologists, and who knows, maybe the hepatologists will also hanker after this class of drugs. So to take us through that, we start with the basics. We start with Dr. Kaushik Pandit, who will take us through sort of how the SGLT2 inhibitors act. And of course, it will be dealt with in his own masterly way, so that you all are not bored. And I know you all have heard, probably this will be the 100th lecture or talk related to SGLT2 inhibitor, but I'm sure Dr. Kaushik Pandit will do justice to the topic. He is a very eminent endocrinologist. He is a consultant endocrinologist at the Bellevue Clinic and the Fortis Medical Center in Kolkata. He's an honorary research scientist in our Department of Endocrinology in IPJMER, and he is secretary of the RSSDI West Bengal chapter. He was also recipient of the Albert Reynolds Young Scientist Award from EASD. So over to you, Dr. Kaushik Pandit, for your initiation of this night's or this evening's discussion on SGLT2 inhibitors.
Thank you. are the benefits, how to use it? Dr. Unikrishnan will tell us more about it. But just to set all rolling and let us understand why this SGLT2I gives us so much of benefit, and many times that benefit goes beyond glucose control. Well, when we talk about diabetes, or something which predates diabetes, that is metabolic syndrome, which starts at the central obesity leading to insulin resistance and thereby giving rise to obesity, type 2 diabetes, dyslipidemia, hypertension. And when we start treating that, we started with various other problems like weight gain, heart failure, renal compromise, hyperuricemia, and we really are in search of agent which can handle all this, probably all this in one go. There are only a handful of agents which can address all this problem in one go. And fortunately, SGLT2I are one of the group of the agents which can tackle so many problems associated with type 2 diabetes because of its mechanism of action. A bit of a history. Well, the beginning of SGLT2, so to say, started with, as we see, on an apple. Well, I'm talking about the real one, not the virtual or not the electronic one in your hand. And if we read the review as is given here, we know that it started much earlier in the year 1835 when French scientists isolated one substance known as florezine from the root bark of the apple tree and found that it causes glucosuria and reduces glucose, ambient glucose. And this has found its application in some diseases, especially malaria. So initially it was, so to say, an anti-malarial drug. And so that's the sort of dubious connection between malaria and diabetes. Now this SGLT2I, we have understood, are the first class of agent which had given us an undisputed evidence of deriving cardiovascular benefit to the extent that it not only reduces sugar, but it reduces cardiovascular disease, especially death and infirmity from, say, myocardial infarction or stroke, etc. But how does it do so? Well, as we understand, SGLT2I has been put into clinical use quite recently, so we do not have hordes of data. So whatever data that we have on SGLT2I, I would try to restrict myself only on the relevant one. And I'm sure just because you have been listening to SGLT2 inhibitors for quite some time, n number of lectures, so I wouldn't like to go into its property of reduction of glucose in the blood and its ways and means of doing so. Rather, I would concentrate beyond glucose. Let us look into the effects, direct effects of SGLT2I on the cardiovascular system. One important aspect of SGLT2I that it has got receptors in the myocardium. This SGLT2 type of receptor in the myocardium, like kidney, also causes an exchange of sodium and hydrogen, and therefore it improves the cardiac function. It increases the concentration of sodium inside the mitochondria, the powerhouse of the cell, and thereby the effect is shown as a better myocardial pumping. It reverses the electrolyte disorders in heart failure. Therefore, the heart works better in such situation. The myocardial energy metabolism is shifted mostly towards the ketone rather than glucose, which uses much less oxygen. So therefore, the oxygen demand also goes down. This certainly has got a significant degree of benefit in people who have got compromised cardiac circulation, especially if the person has got diabetes, where it is known to have so. This SGLT2I also promotes ATP energy storage, so they can work in an adverse situation when there is also lack of oxygen. The ATP can be generated and used, and it independently increases myocardial oxygen supply. I mean, all this came out of very many studies, and all the studies have not been able to answer how exactly does it so, but these are the results that we have. Now, apart from that, it increases oxygen uptake and transformation at the myocardial level. Mitochondrial level. It increases generation of ketone bodies. That we know that one of the flip side of usage of SGLT2I, where it can lead to ketosis, which may not be very beneficial in some situation, and we need to be cautious in its usage. And as we know that it shifts the metabolism from glucose to ketone and lower the insulin to glucagon ratio. This improved glucagon and reduced insulin works better in the situation of the cardiovascular system, where the compromised cardiac function, compromised cardiac circulation improves with this change ratio. And with time, the effect of SGLT2I manifests itself in reducing the myocardial fibrosis. Therefore, the good effect of good cardiac effect continues for a longer period of time. This SGLT2I also known to have reverse myocardial remodeling. I mean, with so many benefits built into this one group of agent, is surely likely to show some effect in the clinical usage. And if we are looking into the literature, we know that the pharmaceutical industry is building out one after another, starting with empagliflozin, then canagliflozin, then dapagliflozin, then artegliflozin, and so on and so forth, are coming out of their stable simply because of the fact that they are not only a good anti-hyperglycemic agent, but their effect goes beyond glucose control in improving the cardiovascular system. And therefore, the patients who have got compromised cardiovascular function would derive a bigger benefit. I mean, people with diabetes. SGLT2I also have got some other important direct effects on the cardiovascular system as well. It reduces cardiac preload by causing increased osmotic diuresis, and it reduces the myocardial oxygen consumption, as we have seen earlier. And this diuresis is a little special in the sense that it improves the free water clearance, in the sense that it excretes more of water. There is natriuresis, but there is also diuresis as well. And this greater fluid clearance from the body is manifested as greater fluid clearance from the interstitial space rather than from the circulation. It is true that from circulation some amount of fluid is cleared, but it is more important that it is the interstitial space, which is the storehouse of maximum amount of extracellular fluid, derives the benefit. And so we see a minimal impact on the blood volume, minimal impact on the arterial filling, and there is minimal impact on organ perfusion. So despite the fact that there is diuresis, despite the fact that there is good amount of free water clearance, the volume decreases, but that volume decrease does not decrease the arterial filling or organ perfusion. So therefore, it is certainly a win-win situation. It also reduces afterload by reducing the blood pressure, by increasing the osmotic diuresis, and increasing urinary sodium excretion. In addition, the SGLT2I have got direct effect on the cardiovascular system in the sense that it reduces oxidative stress, it improves the endothelial function, it certainly causes a reduced myocardial or cardiomyocyte apoptosis, therefore more amount of cardiomyocytes are available, and it prevents the remodeling, which reduces the heart function or heart pumping efficacy. SGLT2I reduces the TGF-beta production and macrophage polarization. Therefore, the fibrosis, the process of fibrosis is reduced or delayed. So there is reduced myocardial fibrosis and remodeling. There is, in addition, there is attenuated sympathetic nerve activity. All these working in unison is surely going to improve theoretically, theoretically the effect of the pumping function of the heart. Does that show any effect in the clinical trials? Well, it is. An important trial like DAPA heart failure trial or Emperor reduced trial had shown that it really happens in real life, that the effect of the laboratory effect of the SGLT2I on the reduction of preload and afterload manifests itself as a better heart failure function in patients with SGLT2I. In addition, as if this is not enough, this SGLT2I also have got indirect effects on the cardiovascular system as well. This SGLT2I, by its mere effect on the as an anti-hyperglycemic working through the kidney on the proximal tubule, improves hyperglycemia, improves the blood glucose condition, and therefore, while considering a betterment of the cardiovascular system for any anti-hyperglycemic agent, the question of glycemic equipoise is, taken into account. What I want to mean is that the effect of the SGLT2I is not derived merely because of its improved glycemic parameters, but it goes beyond that. So in two groups of people, where in one group there is SGLT2I is applied and in other there is a standard treatment of diabetes, and in both the groups they achieve a good glycemic control to the similar extent. In the SGLT2I, the cardiovascular system benefit is more. Therefore, meaning that the benefit of the cardiovascular system is derived not only for the glycemic parameter improvement, but otherwise as well. SGLT2I are renowned for its effect on the weight loss, primarily because of the glucosuria and negative energy balance. It reduces blood pressure because of the weight and other issues, including it reduces uric acid and metabolic switching to ketone, which also helps the blood pressure to lower down by 3 millimeter of systolic or 2 millimeter of diastolic. And when you go for the measurement in terms of the ambulatory blood pressure monitoring, the numerical aspect is probably a little bit more. In all, SGLT2I reduces blood pressure to a significant extent. In addition, they also reduce proteinuria and delay progression of the renal disease. All of them have got an effect on the cardiovascular system. So this indirect effect on the cardiovascular system also should be taken into consideration when we are considering the benefits of SGLT2I. Now, let us also think about effect on the kidneys, where we are pretty worried about because of its direct effect on the kidney in causing glucosuria. So thereby, some people thought that it might have some kidney deteriorating effect. But in reality, we found the evidences show that SGLT2I protects the kidney in the long run. It improves the glomerular hyperfiltration This glomerular hyperfiltration is controlled mostly by the tubulo-glomerular feedback, and this feedback is positively impacted with SGLT2I. Therefore, the glomerular hypertension is reduced because of the effect of the SGLT2I, and that if in the proximal tubule, and that effect is manifested through macula densa and goes to the Bowman's capsule, therefore reducing the hyperfiltration that we see in compromised renal function in kidney with diabetes. So there is reduced renal blood flow, especially through the afferent arteriole. The vascular wall pressure is reduced with the usage of SGLT2I. There is reduced basement membrane thickening, and obviously that leads to a less injury to the glomeruli, and this glomeruli remains healthy for a long period of time. Therefore, it is expected that SGLT2I, which in the laboratory shows all this effect, is going to show some effect in the real life scenario. Clinical trials are supposed to pick up this signal. We'll see whether it really is happening. In addition, SGLT2I reduces the renal oxygen consumption, reduces the renal inflammatory reaction as you have seen in the situation of the heart. It restores the mode of the cellular energy metabolism as we have seen in situation of heart as well. So all this works in unison to improve the situation in the kidney. There is also indirect protective effect on the kidney as well. There is improved blood glucose, of course. There is improved blood pressure, both of which have got a positive impact in the kidney. There is decreased uric acid. There is weight loss, which is an independent risk factor for renal deterioration as well. There is increased glucagon level. Glucagon, incidentally, has got a significant effect on the renal filtration and electrolyte excretion. There is decreased insulin level because of improvement in the hyperglycemia and its direct effect on the pancreatic beta cells. There is proliferation of extracellular matrix, and this improves the renal interstitium. There is diuresis effect independently by the SGLT2I. So all this working in unison is expected to cause a lot of benefit. Do we really see such benefit? Yes, the evidences that we have in hand, which will be dealt in detail by Dr. Unikrishnan, we have seen that DAPA-CKD trial or Credence trial or EMPA-Kidney trial had given a signal that SGLT2I really does have benefits beyond glucose control, and it goes to the renal system as well. We must also remember that this SGLTs, that is sodium glucose co-transporters, and we are interested about SGLT2, which is mostly there in the renal proximal tubule, is a family of receptors. We have got SGLT1 to SGLT6. The SGLT1 is mostly seen in the small intestine and other places as well, like trachea and the heart. SGLT2 is mostly seen in the proximal tubules. SGLT3 is once again in the intestine and the lungs. SGLT4 in various other places. And so it is emancipable that the agent SGLT2I can certainly have a cross effect on the other SGLT2, and you can have positive effect, maybe sometimes having negative also. And those effect of the SGLT2I that we know today may be an additional effect of these agents in the other SGLT2 receptors, other SGLT receptors like SGLT1 or 3 or 4, where obviously the effect will be much less, but probably it is theoretically possible. So I would stop here and would invite questions, and would expect that Dr. Unikrishnan will throw more lights on this issue, and would thank you very much.
Thank you very much, Dr. Pandit. As expected, you have done a wonderful job, and you've left out the oft-repeated mechanism of glucose-lowering action of SGLT2, but highlighted more how it could possibly protect organs, especially the heart and the kidney. We now go on up. We'll have the questions at the end. We have a few questions already thrown in, but because the topics are related, we'll have the question session together. So we go on to the next session, which is more directly clinically oriented and which looks at the use of SGLT2 inhibitors today and possibly tomorrow in a sort of figurative sense tomorrow. And to take us through, we have none other than Dr. A.G. Unnikrishnan, who is a very well-known endocrinologist, and actually he's the CEO of the Chellaram Diabetes Institute in Pune. And he does a lot of things. He treats patients who are involved in clinical care. He is into research, education, and also treats not patients sitting in his own clinic, but also oversees a philanthropic rural diabetes care program at the Institute. He has had various accolades against his name. He has several publications, more than 160 publications in index journals, and he had received the Dr. Subhash Mukherjee Oration Award of the Endocrine Society of India, the Srivastava Award of the RSSTI, the Fellowship Award of RSSTI, Dr. Sam G.B. Moses Oration Award by Diabetic Association of India, and so on and so forth. But we would like to hear him speak on the SGLT2 inhibitor, the clinical use of SGLT2 inhibitors as he sees today and in the future. Over to Dr. Unnikrishnan.
Thank you. It's a pleasure being here. And my task is to talk about SGLT2s, the past, present, and the future. I'll try to make my talk crisp and clinical. Dr. Kaushik Pandit in his lecture alluded to the apple tree bark, which contains fluorescein. And this is the discovery of gravity by Sir Isaac Newton from the apple. And SGLT2s are really not very different because the apple tree bark itself contains the glycosuric agent fluorescein, and fluorescein is one of the agents which led to the discovery of SGLT2 inhibitors, and that itself has changed the management of diabetes and now other diseases as well. So I'm going to quickly go through 3 cases and then discuss the NAPA-CKD study, which is the newest study throwing light on SGLT2 inhibitors. So this is a 53-year-old gentleman who came to our hospital with chest pain and diabetes and anterior wall ischemia. And his BMI was high, and he was on saxagliptin, metformin, statin, and metoprolol. And after he underwent an angioplasty, when he was discharged, he was put on a lot of medicines. And when I saw him after a week or 2, when the medicines had further been changed, I saw that he was on GLP-1 receptor agonist, SGLT2 inhibitors, and metformin. And I couldn't stop wondering that about 10 years back, if we saw such a gentleman, these 2 major treatments of diabetes would not be there. Neither would GLP-1 be there, nor would SGLT2 inhibitors be there. And these 2 drugs have really changed the way we manage diabetes today with their cardiovascular protection and now renal protection with SGLT2 inhibitors. I go on to my second case, which is a different case. A 23-year-old gentleman was referred to me with findings of glycosuria. So he's a young gentleman. His HbA1c was 4.7. and he was having urine was always 2 plus, 3 plus, 4 plus glycosuria. His sister had a similar problem during pregnancy and persisted, and his fasting blood glucose was 62. So this gentleman, probably I diagnosed him to have, I worked him up for hypoglycemia because some of the sugar readings were low, but he was losing glucose in the urine, and I made the diagnosis of isolated renal glycosuria, probably familial renal glycosuria, and that was one of the conditions that mimic the action of SGLT2 inhibitors. There are two types of familial renal glycosuria, one in which there is reduced amount of SGLT2 protein, and one in which there is reduced affinity of the SGLT2 transporter for glucose. So just to highlight that familial renal glycosuria is a condition where there is SGLT2 inhibition naturally, and these patients do not have any health problems. They may have glycosuria, but they are asymptomatic. Their blood glucose is normal. There's no hypoglycemia or hypovolemia. There's no other evidence of tubular dysfunction. Kidney biopsies have shown that the histology is normal, renal function is normal. There's no increased incidence of chronic kidney disease or diabetes or urinary infection in these people. So just to highlight that sometimes you can get familial renal glycosurias, which may be because of SGLT2 inhibition. Of course, I didn't do the SGLT2 testing for these people, nor did I do oral glucose tolerance test, but it is said that if you do oral glucose tolerance test for people with familial renal glycosuria, you will get a flat GTT. After taking a meal, the glucose never rises because the glucose is thrown out into the urine in these patients. So we looked at the first case, we looked at the second case. The first case was a case of cardiovascular disease, probably unstable angina, angioplasty was done, and he was on SGLT2 inhibitor, metformin, and GLP-1. The second case was a familial renal glycosuria case where there was a probably it was due to some sort of SGLT2 inhibition naturally. But this is another gentleman, an obese 42-year-old gentleman who came to me. As you can see, his weight is 103 kilos, BMI is 30, and he was on dapagliflozin plus liraglutide plus glargine. So this is just to show you that this combination is associated with good amount of weight loss because he lost a lot of weight with this agent. This was, of course, while we saw him, but this is on 10th of May 2018, and you can see the AGP was done from 25th April to 10th May, but earlier his weight was much more than this, and if I remember right, he lost about 10 to 12 kilos on this regimen. What you will see is that his daily average glucose is 138. If you look at his median glucose levels, the median glucose levels are pretty flat and within the range of 70 to 180, showing you that there is not much intraday variability. And you will see the dark blue and the light blue shaded areas, which suggest that there is very little inter-day variability, day-to-day variability as well. If you see the time in range, 85% of the time his glucose level is in range, which is very good. The recommendation is 70% the time glucose should be in range in CGM. He has zero hypoglycemia and he has some hyperglycemia. So he was on a combination of glargine, U300, liraglutide, and dapagliflozin. And I just showed this case to highlight that now with the availability of multiple agents, you have insulins like glargine, U300, and degludec, which can bring down the blood glucose with minimal hypoglycemia. You have liraglutide, which causes weight loss without hypoglycemia. And you have dapagliflozin, which can cause weight loss without hypoglycemia, control the blood glucose, protect against cardiovascular disease, protect against cardiovascular failure. And now data show that it protects against kidney disease as well. Of course, Dr. Kaushik did allude to this, but what SGLT2 inhibitors do is that they improve the function of the heart. They correct left ventricular hypertrophy. They reduce cytokines and inflammation. They improve the extracellular matrix remodeling. They improve cardiac metabolism. They reduce apoptosis and protect the heart. They also protect the kidney because SGLT2 inhibitors cause efferent arteriolar constriction. This reduces the intraglomerular pressure, which reduces the proteinuria, and this very beautiful picture can be found in the journal Diabetology. I thought a very elegant illustration almost reminds me of a painting which shows how the dilated fibrotic loops seen in diabetic kidney disease can be corrected by SGLT2 inhibitors, which reduce the intraglomerular pressure. And this is, of course, another very elegant picture which looks at SGLT2 inhibitors versus loop diuretics. You can see that loop diuretics reduce the sodium. SGLT2 inhibitors may also reduce the sodium, but not clinically. Loop diuretics reduce the interstitial volume, that is the space outside the blood vessel, outside the cell, which again, SGLT2 inhibitors do that. But where it is different is that loop diuretics do reduce the intravascular volume, whereas SGLT2 inhibitors do not reduce the intravascular volume, so do not predispose to intravascular volume depletion events or hypoglycemia. It has been postulated that this differential volume regulation by SGLT2 inhibitors, interstitial rather than intravascular, may limit the aberrant reflex neurohormonal stimulation that occurs in the setting of intravascular depletion. In other words, if our BP falls, there is a natural increase in the heart rate. But it is seen that in SGLT2 inhibitors, where the blood pressure changes, there is no reflex tachycardia, and that autonomic change is supposed to protect the heart. So we looked at case number 1, in which I showed how SGLT2 inhibitors may help in cardiovascular disease, specifically atherosclerotic cardiovascular disease. Case number 2, I discussed how familial renal glycosuric patients who have SGLT2 inhibition may actually not have any disease, and that means SGLT2 inhibition is safe indirectly. And I showed you a case of an obese gentleman in his 40s, where the combination of Largine U300, dapagliflozin, and liraglutide led to weight loss. And I also showed you how SGLT2 inhibitors may help in protecting the heart, the kidney, and protecting the blood vessels. Now, I want to go on to the DAPA-CKD study, which was recently presented at the European Congress of Cardiology, European Society of Cardiology Congress, which is a landmark study because this was done in people with or without diabetes. So they took 4,744 people, age more than 18 years, with or without type 2 diabetes, with a diagnosis. Sorry, this is the DAPA-HF study, not the DAPA-CKD study. I thought before the DAPA-CKD study, I'll talk about the DAPA-HF study. And the DAPA-HF study very clearly showed benefits of dapagliflozin. And that brings us to the DAPA-CKD study. Just to highlight, the DAPA-HF study showed that dapagliflozin reduces the risk of hospitalization for heart failure or CV death, both in diabetes and non-diabetics. So this study is important because this was the first study to show that dapagliflozin could reduce a clinical event in people without diabetes as well. Just to highlight this study once more, a DAPA-HF study studied 4,744 subjects with symptomatic heart failure or LVF, heart failure with reduced ejection fraction. Dapagliflozin or placebo was given, and you can see that diabetes was present in 42% of people, pre-diabetes was present in 37% of people, 18% had no diabetes, no pre-diabetes. And you can see that dapagliflozin reduced the risk of heart failure hospitalization or urgent heart failure visits by about 26%, with a number needed to treat of 21, suggesting that there was a 26% relative risk reduction and that dapagliflozin could reduce heart failure events even in people without diabetes. So then we look at the landmark DAPA-CKD study. DAPA-CKD study was presented in the European Society of Cardiology Congress recently. And the rationale for the study was to see whether dapagliflozin could protect against CKD in people with or without diabetes. The key inclusion criteria was age more than 18, eGFR 25 to 75, urine album creatinine ratio more than 200, on stable doses of ACE inhibitors and ARBs, and with or without diabetes. Of course, they ruled out some specific kidney diseases like lupus nephritis, polycystic kidney disease, and ANCA-associated vasculitis. 10 mg dapagliflozin was given to one group, or placebo was given to the other group, and the follow-up period was 2.4 years. The primary outcome was a composite endpoint of a sustained more than 50% decline in EGFR, end-stage kidney disease, renal or CV death, and there were a lot of secondary outcomes. So at the end of 2.4 years, the study results were published, and a lot of people, including 201 patients from India, a wide geographic range of the study, 21 countries, 386 sites. And if you see, the baseline characteristics were balanced between the dapagliflozin group and placebo group. The age was similar, gender was similar, type 2 diabetes prevalence was similar, 68% in both the groups. 97% of these people were taking ACE inhibitors or ARBs. And if you look at 58% had diabetic kidney disease, but some people had ischemic or hypertensive nephropathy, some people had IgA nephropathy, some people had focal segmented glomerular sclerosis, some people had membranous nephropathy, some people had minimal change disease. And if you look at the diabetic kidney disease, you can see that 3.3% had other such kidney diseases. And if you look at the people without diabetes, you can see that ischemic hypertensive nephropathy and chronic glomerulonephritis were the two big groups. So you can see there was a mixed bag of people with diabetic nephropathy and without diabetic nephropathy. And just to show you the results, this is just to show you the characteristics. But what the results showed is that at the end of 2.4 years, there were 312 events in the placebo group and 197 events in the dapagliflozin group. And this resulted in a hazard ratio of 0.61, which means there was a 39% relative risk reduction. So if you choose people with a low EGFR between 25 to 75, whether they have diabetes or no diabetes, and if you give 19 people dapagliflozin, the number needed to treat is 19, you will prevent one composite event, which could be a 50% EGFR decline, presence of end-stage kidney disease, which means an EGFR of 15 or need for dialysis transplantation, renal or CV death. If you look at why this primary composite outcome was reached, all the components. So if you see this line stands for a risk reduction of hazard ratio of about 0.62, and this is for one is neutral. So you can see, except for CV death, all the renal parameters, whether it is EGFR decline, the end-stage kidney disease of EGFR less than 15, need for dialysis, all these were significantly reduced by dapagliflozin. So yes, all components contributed equally. The p-values were all significant. Of course, the number which required transplantation numbers, the renal death numbers were very small to contribute, but all the others contributed very significantly, and the p-value was 0.000000028, which was highly persuasive, and you can see the confidence interval very good. So if you see the primary composite outcome, it was consistent whether there was type 2 diabetes at baseline or no, urinary albumin creatinine ratio above 1000 or below 1000, EGFR above 45 or below 45. And you can see the p-value for interaction was not significant, suggesting that dapagliflozin was better. So the primary composite endpoint across pre-specified groups also showed that the treatment benefit was consistent regardless of age, gender, race, geographic region, and systolic blood pressure above or below 1. Though the systolic blood pressure showed some p-value for interaction, which was significant, the rest of it was really not significant. So if you see the secondary endpoint, again, this highlights there was a 44% reduction, relative risk reduction in the secondary endpoint, which is exclusively a kidney endpoint, death endpoint here. So the EGFR reduction of more than 50%, end-stage kidney disease or renal death. And you can see that all heart failure hospitalization and CV death was also reduced. What they also found is that all-cause mortality was reduced significantly, and safety outcomes were pretty in line with what was expected. So to summarize, why the DAPA-CKD study is important is that it showed in a dedicated renal outcomes trial for the first time in people with and without diabetes in CKD patients, there was a strong renal benefit of dapagliflozin, of SGLT2 inhibitors. And this was seen in people with and without diabetes. Safety profile was confirmed, and this builds on the evidence of other SGLT2 trials. So if we look at the DECLARE trial, which showed cardiovascular protection, DAPA-HF study, which showed heart failure protection with people with and without diabetes. Now the DAPA-CKD showed kidney protection in people with and without diabetes. So the DAPA-HF study showed some secondary outcomes benefits in renal endpoints, and the DAPA-CKD study showed some secondary benefits in heart failure. So where are we headed? If you look at the ADA 2020 guidelines, the guidelines say that metformin is a first line of drug after lifestyle modifications, and I completely agree with that. But where metformin isn't enough, where atherosclerotic cardiovascular disease or heart failure predominates, I think an oral agent would be preferred by most Indian people, and there you have to use an SGLT2 inhibitor with proven CVD benefits. I'm not going to talk about which SGLT2 inhibitor is beneficial. We could discuss it, but definitely SGLT2 inhibitors would be beneficial for atherosclerotic cardiovascular disease, heart failure, or CKD, whichever predominates. I think the use of SGLT2 inhibitors would be ideal. So independent of glucose control in these patients with diabetes and high risk. But now, where we are headed is that SGLT2 inhibitors are going to be used in people without diabetes to protect them from heart failure and kidney disease. So isn't the journey fascinating? As Dr. Kaushik Pandit said, right from florizin, from the apple tree bark, the gravity of the situation was that the derivative of florizin could cause glycosuria and control sugars. We found that it controls blood sugars, SGLT2 inhibitors, reduces weight, reduces blood pressure. We found that it protects against cardiovascular events. We found that it protects against kidney disease events in people with diabetes in the CREDENT study. Then studies started being done in people without diabetes. And then we found that in people with and without diabetes, dapagliflozin reduced heart failure events, and in the EMPEROR-reduced study, empagliflozin reduced heart failure events as well, especially heart failure with reduced ejection fraction. And finally, in people with and without diabetes, the drug is now being effective for CKD. So an anti-diabetic drug, which could protect the heart and the kidney, becomes an anti-heart failure drug and an anti-kidney disease drug, even in people without diabetes. So that has been the fascinating journey of SGLT2 inhibitors. And over to Sir Dr. Shubhankar Chaudhary and to Dr. Kaushik Pandit for a discussion.
Thank you very much. It was a wonderful talk covering the entire gamut over which the SGLT2 inhibitors could help our patients. So we go on to the questions, and maybe for Dr. Kaushik Pandit, I would start with a provocative one, because you said that it's good because it tends to cause ketosis, it tends to shift metabolism from glucose to ketones. So then we shouldn't be treating diabetic ketoacidosis. Let them have the ketoacidosis.
Well, people with SGLT2 usage can land into a situation of euglycemic ketosis. In contrast to the diabetic ketoacidosis, where there is associated hyperglycemia, there is no hyperglycemia, but they can land into ketosis. And this uncontrolled ketosis certainly is detrimental because it leads to deterioration in the whole metabolism, including the kidney. There is uncontrolled acidosis as well. But barring those exceptions, which are exceptional situations, if you are careful not to use SGLT2 inhibitors in people who have a compromised metabolic milieu, especially in and in presence of a significant degree of infection. Otherwise, this shift of from from this glucose to ketone is beneficial, especially for the heart. Heart usually uses ketone as its standard fuel, and if it needs to use glucose, more amount of oxygen is needed, which may be a difficult order for compromised circulatory situation of the heart in patients with diabetes. So if the situation shifts towards ketone, probably it is better for the heart. But if it goes beyond control, obviously it will lead to a significant degree of ketosis.
Right. So we need to have a sort of controlled increase in ketone levels. Yes. And in fact, if you look at the beta hydroxybutyrate levels, which is the best marker of ketone body production in the body, so if you are using, if you check those levels in those who are on SGLT2 inhibitors, the levels are increased above basal levels, maybe this doubling of the levels, but it's not above 1 millimole per liter. Whereas when we talk of ketoacidosis, diabetic ketoacidosis, the levels are 4, 5, 10 millimoles per liter. So clearly those high levels are associated significant acidosis. They are of course not helpful for our body, but small mild degrees of ketones possibly are better for the heart to utilize. The other aspect that you highlighted was the diuretic effect of SGLT2 inhibitors. But we have so many diuretics in the market. None of these have actually shown any mortality benefit even in the treatment of heart failure. They are great agents to use in acute heart failure, reduce your symptoms very well, but they have not been shown to improve mortality. But with SGLT2 inhibitors, you have some data at least to show that may improve mortality. Why is this difference?
I mean, as Unni had touched on this issue, that there is a difference in the type of diuresis. The standard diuretics causes diuresis, natriuresis, and decrease in the interstitial and intravascular volume. In contrast, the SGLT2I also causes diuresis, some degree of natriuresis. It reduces the extravascular volume much more compared to the intravascular volume. So this less degree of loss of intravascular volume does not lead to the RAS system activation, which probably is the answer that why this is different than the standard diuretic, and therefore the diuretics probably does not lead to a mortality benefit, whereas the SGLT2Is are probably having the mortality benefit because of this reason. In addition, the SGLT2Is, because it does not decrease the intravascular volume to a large extent, does not lead to a sympathetic overactivity, which can also be another aspect of the story, because this increased sympathetic overactivity would lead to increased oxygen consumption by the heart, and in a compromised situation, this can be definitely a problematic situation. So probably these two aspects acting in unison, or other unknown aspects, are separating the standard diuretics from the SGLT2 induced diuresis.
Right. And there's another question from Dr. Siddhanto. He wants to know what is the possible mechanism of beneficial effect of dapagliflozin in the DAPA heart failure study, even in non-diabetics. So but of course you have mentioned the possible mechanisms. Maybe it will be good to summarize once more as to potential. We do not know exactly what is the cause, but what are the potential mechanisms by which it helps?
Well, as you have seen that SGLT2 inhibitors, including dapagliflozin, have got a direct effect on the heart, including reducing the preload and afterload, therefore reducing the load on the heart and improving the systolic action. Obviously, this leads to much less hospitalization and improvement in the heart failure status. So people who are having heart failure, irrespective of the fact whether they have got diabetes or not, if given dapagliflozin, improves the scenario. I presume the same thing will be seen with canagliflozin or empagliflozin or others. And in addition, it also have got an indirect effect on the cardiovascular system. It has got direct and indirect effect on the renal system. So an improved renal system and certainly improved cardiovascular system so far as the the oxygenation and the preload and afterload leads to this beneficial effect in heart failure.
Right. Now, to turn to Dr. Unni, very important question from Dr. Ahmed. So, you both have suggested that this class of agents have beneficial effects on the vascular system. So what about peripheral arterial disease, someone peripheral arterial disease? So should we use it enthusiastically, or from the Canvas study, we should withhold the use of SGLT2 inhibitors, or we use it with caution? What should be our way to go?
So interestingly, the black box warning box label on canagliflozin has recently been removed. So amputation is no longer a worry. Having said that, I would use empagliflozin and dapagliflozin in both mild and moderate peripheral arterial disease. I would not use empagliflozin or dapagliflozin in severe peripheral arterial disease. Nevertheless, to be conservative, canagliflozin, I may not use it even in mild or moderate peripheral vascular disease, but or severe peripheral vascular disease. So this would be my practice. But I must highlight that at this point, the link between SGLT2s and peripheral vascular disease and amputations has now become very tenuous, and it's probably a chance effect that Canvas study showed canagliflozin induced amputation. Nevertheless, given that the label still states amputation risk, though the box warning has been removed, the label still states it's better to be conservative. So no peripheral vascular disease, mild peripheral vascular disease, moderate peripheral vascular disease, use empagliflozin and dapagliflozin. Canagliflozin restrict to people without peripheral vascular disease or even with mild peripheral vascular disease, but not moderate.
Right. The other question is from Dr. Satvik Siddhanto. From the DAPA-CKD study, extrapolating from the DAPA-CKD and also possibly in the Canvas study, so would you be using SGLT2 inhibitors in eGFR below 45, let's say 30 to 45? Would you be using the SGLT2 inhibitors? That's also very clinically.
Yes, I completely agree, sir. So I think 45 is the general cutoff. Now, after seeing the DAPA-CKD, I probably would use it up to an eGFR of 30. Though the DAPA-CKD has just come out a few weeks back, I haven't yet got down to using it. Till the DAPA-CKD, my practice was above an eGFR of 45, I would use it. But if on SGLT2 inhibitors, the eGFR dips to below 45, up to 30, I would continue to use it. So interestingly, there was a study of credence data in the people whose eGFR dipped below 45, did not dip below 45 in these two groups, and they found very interestingly that the outcome wasn't different. So even in the dippers, you can still use SGLT2 inhibitors up to 30 is what I feel.
Right, but still that would be off-label as of now. I'm not aware DCGI having changed the cutoff for use in this condition. But of course, as we understand, in lower eGFRs, the SGLT2 inhibitors possibly will lose their anti-hyperglycemic efficacy, but may not lose its beneficial effects on the heart or the kidney, at least on the heart. Possibly this may still be there. And then maybe for either of you, for either of you, the important question that has come up is, should we use SGLT2 inhibitors ahead of other agents after metformin? So especially if you have, maybe someone has got just obesity, obese type 2 diabetes, failed on metformin. So what will be your next choice? Will it be SGLT2 inhibitor or will it be something else? There is no known cardiovascular disease. Sorry. No known cardiovascular disease. So what will be your choice? Am I audible?
If Dr. Kaushik can take that, then I can take that.
Somehow I can't hear what's happened.
Okay. Yeah, in that situation, well, SGLT2I would be...
I'm audible?
Yes. Yes, sir.
Am I audible?
Yes, you are audible.
I can't see. I can't hear you. Hopefully, everyone else can hear Dr. Unni.
Yeah. Yes, Unni is audible. Unni, please go ahead. Unni,
Okay.
please take up the situation.
So now the question was, can you...
I mean, the question was an obese type 2 diabetes, uncomplicated. Would you like to use SGLT2I in this situation?
Yes. Now I remember the question. What Sir said is that, Sir was asking, after lifestyle and metformin, would we like to use SGLT2 earlier than later? So I was just interestingly going through the Wikipedia study this morning just to refresh. And I found that the risk of myocardial infarction was not lowered with intensive glucose control. But I'm just wondering that if SGLT2 inhibitors were there in the intensive group alone, would it have shown a benefit? So I started thinking that SGLT2 inhibitors are not to be thought as purely glucose-lowering drugs. They are to be thought as organ protective drugs, protecting the kidney, protecting the heart. And if we think of organ protection as a priority, I agree that after lifestyle metformin comes, but after that, I think we should use SGLT2s more often. Well, cost is always a problem in Indian scenario, but in a couple of years, I think some of the SGLT2s may go off patent, and just like vildagliptin, the price will come down. And I'm sure that by then, this class of agents will be used earlier and earlier. It's mainly the price and the worry of some side effects holding it back. But in practice, we know that with good advice and education, problems like urogenital infections and other problems do not contribute significantly to the side effects. And still, you have to be careful and cautious. But I'd like to see it being used earlier and earlier in practice. But after metformin.
This is really an interesting game for me. I had to, I can't hear anyone. So maybe I'll log out and try to log in. So I'm sure Unni would have given a wonderful answer. And if maybe Unni and Kaushik, maybe Unni, if you can take over and just look after the answers, maybe I'll try to log in again and hopefully I can hear others as well.
Sure, sure. So, Dr. Kaushik, would you like to comment on this? What is your take on this issue? Whether we should use SGLT2 after metformin? Do you think before metformin? Some of the endocrinologists from Calcutta are actually saying use it before metformin. What's your view on that?
I mean, I am rather a little conservative in the sense that just because you have been using metformin and you metformin to the core, probably it comes not only into the pain first, it comes to the mind first as well, and we have got a lot of confidence in it. We know that we have been using it for decades, even much before I started practicing. So we have got such a huge amount of experience on the one, and we are confident that it does not lead to any sort of infirmity or significant degree of morbidity or mortality. Whereas SGLT2I have come into the picture recently for the last 3-4 years, has gained popularity not only because of its efficacy, but because of its evidence base. And based on that, obviously, I think the usage is increasing because of the evidence base. And I'm sure, as we have said, I'll just show you a line that with decreasing cost of the availability of the SGLT2I, the usage is certainly going to improve because we are falling back on evidence-based medicine these days. not only for the sake of better understanding, but for the better legal aspect as well. So I'm sure this SGLT2I is going to increase the usage with days to come. Unless and until we are besotted with the new information that it leads to this significant side effects, which it had not shown with even with 4 or 5 years of usage and for 10 years of at least clinical trial data.
Thanks both all of you for bearing with me. I can now hear everyone. Can Unni sort of provide us what advice do you give to your patient when you start on an SGLT2 inhibitor, what to expect and what not to expect, and so on? A brief one.
So I begin by, as Dr. Kaushik said, I'm also quite a conservative doctor. So I begin by telling the patient, see, after metformin or whenever I decide to start SGLT2 inhibitor, I tell my patient, see, there are two things you need to know about this medicine. One is the good things and one is the bad things. So let me tell the bad things first. I tell them the bad thing is that you may increase the risk of your urogenital infections, which can be, of course, corrected if you drink lots of water, to maintain urinary hygiene. It can be corrected. And also when the glucose comes down in the blood, glucose urea will come down, it will get better. Second is because many people nowadays are following the intermittent fasting and keto diet. In those people, I warn them against following these diets because people on intermittent fasting and on keto diet run the risk of euglycemic ketosis. So I tell them about these two things. The third thing I tell them, because it's a pandemic in progress, the COVID pandemic, I tell them that, okay, now, in case you do get a viral infection, if you do not have symptoms, continue the drug. If you have mild symptoms, you might continue the drug, like some mild nasal irritation or something. But if you have symptoms and if you are symptomatic enough to need to visit a clinic or a hospital, it's better to stop the drug and be on insulin. So these are the two or three negative things that I say. Then I tell them the good things, that you will lose weight, your blood pressure will improve, your blood glucose will improve, you will protect your heart from heart attacks and heart failure, you'll protect your kidney from kidney failure, and then I leave the choice to the patient. But usually by the time I complete this, the patient will usually agree to take SGLT2 inhibitor, is my experience, and I also write in the prescription that there is a chance of urogenital infection. And sometimes if my patient is not from Pune and they come from very far off and they're not going to be able to reach in a jiffy, what I will do, I'll also write an antifungal agent along with the prescription, so that if they do get a thrush or a melanoposthitis in the case of men and thrush in the case of women, they are able to handle that problem on their own. So this is a precaution that I take in most patients.
And what about weight loss? I mean, do you counsel them or do you say that it's likely to cause weight loss?
Yes, but I say that it causes a weight loss of only about 3 kg, because over expectation is also going to lead to problem. Yeah. Though I have some patients who have lost 10 kg, but I just tell them, see, the weight loss may be 3 to 4 kg, but that's good enough for you for a clinical improvement. So I do tell them about weight loss.
Right. Similarly, when we talk about improvement of blood pressure, I think we also need to counsel them that doesn't mean that they stop their antihypertensives. It's unlikely, very uncommon for them to go into hypotensive episodes. Sometimes you could do in elderly subjects with loss of fluid, that could happen, but usually it's not that severe in effect that antihypertensives otherwise can be stopped. So I think there's a final question which all of us could give our answers. It's a Dr. Ahmed that posed a drug-naive patient with ASCVD. Do we start with SGLT2 inhibitor or do you still start with metformin? I think Dr. Unnikrishnan has suggested that he would still start with metformin. I would say I would also still start with metformin. And what does Kaushik Pandit say? Would he now start with SGLT2?
No, I'll start with metformin and see the result and then decide. Surely not SGLT2 first.
Right. So that's the message. So I think we have strong agents, very effective agents in the form of SGLT2 inhibitors, and which at least theoretically and also now practically seems to be agents that sort of address multiple issues of diabetes. And so it not only does reduce the glucose levels, also improves blood pressure and also reduces events. And so we should be using it more and more. And again, as cost, possibly, hopefully, if it comes down, we can use in more number of patients. I think I would profusely thank both our speakers this evening who did marvelous job. Dr. Kaushik Pandit initially with the very basics, but did it in a lucid way. And Dr. Unnikrishnan in his own way, providing the clinical usage of the SGLT2 inhibitors. We can now maybe go over to, is it Mr. Amit Arora or Dr. Mithilesh Nayak? The organizers now. Thank you, all of you, and all our participants. And we have more than 250 doctors this evening, and we know the IPL has started. But despite that, I'm sure there is attraction for Unni and Kaushik as well. Thank you very much.
Thank you, Professor Shubhankar sir. As we come to the close of this fourth edition of Practice Pulse in Endocrinology, on behalf of Zenith Division of INTAS, I, Amit Arora, would like to thank all the viewers who joined in today from different parts of the country. The number of registrations were around 1,500 today, sir, and we had around 1,300 doctors live watching this program today. I am sure today's webinar has contributed in some ways in better management of diabetes patients with multiple risk factors. I must thank Professor Shubhankar Chaudhary, who has been guiding light in this program. I must thank Dr. Kaushik Pandit and Dr. Unnikrishnan for their masterly deliberations on current status of SGLT2 inhibitors. I thank the support team of INTAS for doing an excellent coordination. Fifth edition of Practice Pulse in Endocrinology is scheduled on 3rd Saturday of October, that is 17th of October. In this edition, Professor Shubhankar Chaudhary has planned a very interesting debate on age-related morbidity can be mitigated by hormones. And we have two fierce debaters for this program, Dr. Jubin Jacob from CMC Ludhiana and Dr. Chitra Selvam from MS Ramaya Institute, Bangalore. So please do join us then on 3rd Saturday of October, that is 17th of October. And we once again thank you one and all for joining in today. Dr. Shubhankar, Dr. Kaushik, Dr. Unnikrishnan for a wonderful deliberation today, and have a happy weekend ahead. Thank you very much, and we look forward to meeting you again next month on 17th of October. Thank you very much once again.
Thank you. Thank you very much.